Hello, my name is Dr. Lee. I'm the Chief of Division of Thoracic Surgery and Surgical Director of the Thoracic Oncology Program. Today I'd like to discuss with you about the treatment of early stage lung cancer. Lung cancer is an epidemic worldwide. There's approximately 1.8 million patients that are diagnosed with new lung cancer. Almost equally, there were 1.6 million patient deaths attributed to lung cancer. In the United States, we have an incidence of 224,000 patients that were diagnosed in 2011, and that's our most recent data is 2011. And almost equivalently, there was 159,000 patients that developed a mortality related to lung cancer. Based on the International Association, the IASLC for lung cancer, there's a retrospective database that's collected, and in that registry, adenocarcinoma was the most common type of lung cancer. It accounted for 43% of non-small cell lung cancers. The second most common non-small cell lung cancer is squamous cell, and it comprises of about 25%. A minority of lung cancers are what's called small cell type, which makes up about 8% of lung cancer types. So the two major types are non-small cell and then small cell lung cancer type, and several less common types of lung cancers with variable prognoses. But most patients will be diagnosed with adenocarcinoma or squamous cell carcinoma. Lung cancer will present with symptoms that are fairly nonspecific. Based on previous studies evaluating 3,500 patients that presented with lung cancer, the most common types of symptoms they presented with included coughing, weight loss, dyspnea or shortness of breath, chest pain, hemoptysis, which is coughing up of blood, bone pain, and hoarseness of voice or a change in the voice. These were the most common types of symptoms that patients presented with. Often those symptoms will precipitate studies and workup. Additionally, important are risk factors for lung cancer. The most common cause of lung cancer is related to smoking. 90% of lung cancers are linked to smoking. There's approximately a 15 to 30% more likelihood of developing lung cancer compared to non-smoker control patients. Smoking has, cigarette smoke has approximately 7,000 chemicals, 70 of which have been shown to cause cancer in humans and in animal studies. There's an increasing number of patients with secondhand smoke exposure that die from lung cancer. 7,300 patients will die every year secondary to secondhand smoke exposure. These are often family members that are exposed growing up. Or radon, which is an inert gas. You can't smell it. You can't see it. Radon gas percolates from the ground up. It causes 20,000 cases of lung cancer each year. The Environmental Protection Agency estimates that 1 in 15 homes in the United States will have high radon levels. Other substances that have been associated with lung cancer include some of these that are listed here, most commonly asbestos exposure, and these have been shown to increase the risk of lung cancer. Personal and family history of lung cancer, there's increasing studies that attribute lung cancer to genetic relationships. So family history is playing more of a role in patients that are at risk for lung cancer. Patients that have had radiation therapy to the chest in the past, often these are patients that are cancer survivors from breast cancer or lymphoma, and they receive radiation to the chest as part of their treatment. These are cancer survivors, but later on in life they develop lung cancer because of the exposure of the lung to the radiation that they received in the past. There's increasing studies that relate diet to lung cancer development. most notably smokers that take beta-carotene supplements have been shown to have increased incidence of lung cancer. Arsenic, which is a chemical found in drinking water, has been attributed to, related to increased risk for lung cancer development. So the combination of symptoms and risk factors will often prompt workup and additional studies to look for what is causing the patient's symptoms or when there's a concern for development of lung cancer. Signs and symptoms that we covered will often precipitate either a chest x-ray or a CT scan to begin with. Risk factors in asymptomatic patients can precipitate a screening CT scan, a low-dose chest CT scan to look for lung nodules and lung cancer. Based on these studies, understanding the staging system is critical to how we interpret these radiographic exams and also how treatment is tailored for patients with lung cancer. The physicians talk about TNM staging. T stands for tumor, N for nodes, lymph nodes, and M for metastasis. It is a common language that clinicians use to figure out and talk in a language that can describe a patient's extent of tumor, how much and where has the cancer spread. Cancer can spread through the tissue itself within the lung. This is a cartoon depiction of a patient with the lungs exposed here. Lung cancer can spread to lymph nodes that exist in the lung itself, lymph nodes that exist outside of the lung in the center portion of the chest called the mediastinum. And in this picture, it's surrounding the trachea and the airways. There are other lymph nodes outside of the lung, up in the lower aspect of the neck. These are some other areas where lung cancer can spread to. So lung cancer spreads to lymph nodes not only within the lung itself, but it can also spread outside of the lung. When cancer spreads beyond the chest and goes systemically, it spreads through the bloodstream and goes to distant places outside of the chest. This is the latest stage. It goes from stage 1 to stage 4, and lung cancer can go to many different places, most commonly the brain, the liver, the adrenal gland, and bone. So the extent of the tumor spread is what determines the patient's stage and defines the TNM staging. How we figure out the TNM staging for patients, most commonly to figure out if it's spread to these sites, the lungs, the lymph nodes, or the rest of the body, we utilize these two scans, a whole body PET CT scan or a head MRI, brain MRI. This is a picture of a fused PET CT scan. What it does is that the PET scan is a nuclear medicine study. It utilizes a radio-labeled sugar molecule, glucose, and glucose preferentially goes to cancer. It can be taken up by tissues that are irritated or inflamed, and the PET scan is superimposed onto a CT scan, and we come up with what's called a fused PET CT scan image. And in this picture, this is the patient's back, the front, and in these windows, the black area is the right lung, the black area over here is the left lung, and the heart's in the center. And this area that lights up is a lymph node as soon as right at the entryway into the right lung. This picture here on the PET CT scan shows the actual lung cancer within the right lung itself. But this PET CT scan can show us not only lymph nodes, but other areas of spread of the cancer to other distant sites. However, the brain MRI is really what's utilized to see if there's any spread to the brain itself. So the radiographic staging is to look for sites of disease that have spread from the lungs to lymph nodes, and also, more importantly, has it spread outside of the chest. The surgical staging, or the more invasive staging, is to look at the mediastinal lymph nodes. Clinicians think of the chest as being the right chest, the left chest, and the center component called the mediastinum. And in this center compartment lives many important organs, but also the lymph nodes that are outside of the lungs surrounding the main airway. These lymph nodes are important for staging the patient and guiding treatment. So accurate staging of these lymph nodes can be performed by endobronchial ultrasound and endoscopic ultrasound. This is similar to a colonoscopy. It's a flexible camera scope. It has an ultrasound at the end of it so that you can see across the airways. We call this an endobronchial ultrasound. It's a flexible black scope, and the endobronchial ultrasound can go down the airway, look across the airway, and needle biopsy these lymph nodes. And in some instances, we can even needle biopsy lung tumors. The endoscopic ultrasound goes down the esophagus and is able to needle biopsy these lymph nodes as well. The surgical approach to it is to make a small incision. It's outpatient surgery. It's minimally invasive. We make a small incision at the base of the neck, put a scope down, and surgically biopsy these lymph nodes. A combination of either or both are used to accurately stage the patients by biopsying these lymph nodes. The PET-CT scan can give a hint about if they're spread to these lymph nodes, but the most accurate way is to biopsy them. And this really guides treatment. It defines the roles of chemotherapy, radiation, and surgery and the timing of them. And not everybody needs all three modalities, but the staging is important in figuring that out. Lung cancer surgery, most of the time, depending on the stage and the extent of the disease, but most of the time at UCLA we will perform the lung surgery using minimally invasive techniques called video-assisted thoracic surgery, or VATS. It's also called thoracoscopic surgery. And in this picture, our ideal operation is to do a lobectomy, which is, in this picture, the right lung has 3 lobes, upper, a middle, and a lower lobe. And on the left side, there's an upper and a lower lobe. There's a fissure, which is a natural division that occurs in the lung and actually slices the lung from a front to upward towards the back direction. And that separates the lung. So there's 2 lobes on the left side, 3 lobes on the right side. We make small incisions, usually 3 small incisions. There's no spreading or removal of the ribs in this approach. We use a camera scope. These are the 3 small little incisions on the side of the patient. We use a camera scope to go in, and we take part of the lung out and the lymph nodes as a treatment for the patient's lung cancer. The minimally invasive approach is associated with earlier recovery and less pain. At UCLA, we participate in the Society of Thoracic Surgeons database. This is a national database that measures quality benchmarks. This is our data for last 2 years. Some of this has been updated further from this data point. But our discharge mortality and 30-day mortality at UCLA for lung surgeries was 1.3% and 1.7% compared to the national STS, or Society of Thoracic Surgeons benchmark of 2.3 and 3.3 averages. So lung cancer surgery entails, and in this picture, this is the right lung and the left lung. And the small yellow area is the lung cancer. Lung cancer surgery, the amount of lung that actually comes out depends on a number of factors, but mainly the location and the extent of the tumor, and whether the patient can withstand that amount of lung coming out. Ideally, lobectomy is our standard operation, but in patients that cannot withstand an entire lobe to come out, we will take less than a lobe and take a pie piece of the lung that includes that nodule. We call that a wedge resection, or a segmentectomy, where we will dissect the structures that feed in and out through that area. In some instances, when the cancer is very close to the entryway into the right lung, And in this picture here, an entire right lung can be taken out, what we call a pneumonectomy. The reasons for ideally doing a lobectomy versus something less is based on a very hallmark study as part of the lung cancer study group, the LCSG, a lung cancer study group, in which UCLA was a partner in this effort and was a site for this study and major contributor for this study. This was a prospective randomized trial. That means it was a high-level clinical trial where we compared less than a lobectomy versus lobectomy, and basically it showed that there was higher risk of recurrence, cancer coming back in the lobe, or and a trend towards increased mortality or death when you take less than a lobe. But there are instances where it's appropriate to do less than a lobectomy. There are non-invasive types of cancers like what's called adenocarcinoma in situ, patients that can't tolerate a lobectomy, patients with multiple lung cancers, primary lung cancers that require more lung to come out. There are instances where it's appropriate to do less than a lobectomy. In early stage lung cancer, patients with, who are good risk, who are good risk profile for local treatment, the gold standard treatment has been surgery. However, there are patients that simply don't want to have surgery, who have risk factors and other medical problems that make it prohibitive to operate on them, and patients that simply don't have the lung function to withstand lung surgery. In these individuals, there are other local options. My colleagues in the thoracic radiology department will perform a radiofrequency ablation or cryoablation. Radiofrequency ablation is a way where a catheter is inserted into the patient's lung tumor, and energy, microwave energy, is delivered into that tumor through the probe, and it generates heat and leads to death of cancer cells. Cryoablation is where you take a similar technology, but you actually freeze the tumor and kill the tumor itself. These are non-operative local treatments when patients can't have surgery or don't want to have surgery. My colleagues in radiation oncology will perform what's called stereotactic body radiation therapy, or SBRT. The basic concept is this is a depiction of a patient in this position, in a standing position in this cartoon. And in the CT scan, this is the area of the patient's cancer. And the idea is that if you then take this image and put it in a supine position with the patient in a laying down position, there are radiation beams that come in from multiple different directions, in which in each one of these directions has lower radiation, but when they coalesce and meet in the central area, it causes killing of the tumor. This is different from standard radiation therapy. This radiation approach provides greater delivery of radiation to this focal central area where the cancer is over a shorter course of treatments. Often these treatments are in the order of 3 to 5 treatments, but this is something that's done by our radiation oncology colleagues. And this is really ideal for small tumors, patients who are poor candidates for surgery, patients who have very small recurrences, small ground glass lesions, which most likely represent adenocarcinoma in situ. These types of situations, these non-operative approaches are great to treat. Thank you very much for your time. This is our website for the UCLA Lung Cancer Program. My colleague, Dr. Goldman, will be speaking to you about late-stage lung cancer treatment.
Thanks very much, Dr. Lee. My name is Dr. Jonathan Goldman. I'm an assistant professor at UCLA in medical oncology. I'm the director of clinical trials in thoracic oncology. And I wanted to speak to you today about our treatment, mostly reviewing our treatment for widespread disease or metastatic disease. So this is one of the main things I'd like to get across is really there's been incredible development in the last 5 years. New options are coming up all the time. We really have almost innumerable clinical trials that we are looking at finding new drugs and new ways to combine them to improve our care for our lung cancer patients. Oop, I think I went the wrong way. I may need some help. So we're going to start out by discussing chemotherapy. That is still the mainstay of our treatment, but then we're going to go on to some of the newer directions, what we call targeted therapy, where we treat specific mutations that cause the cancer, and then talk about immune therapy, which has really changed the way we think about lung cancer just in the last couple of years. So just for a brief reminder and review, there are numerous types of lung cancer, but most of them these days are non-small cell lung cancer. And those can be split up into subgroups, squamous cell, adenocarcinoma, and others that are often called large cell. A smaller group of patients has small cell lung cancer, and then an even smaller group has mesothelioma. So just really briefly about small cell lung cancer. This is one of the most highly tobacco-related cancers. It's a very aggressive and fast-moving cancer. Surgery is used rarely. We usually focus our treatment on chemotherapy and sometimes radiation. We are looking at some new options at UCLA. Targeted drugs called Notch inhibitors may be showing some promise, as well as PARP inhibitors, which were really developed for other diseases like breast cancer, but may have a role in small cell lung cancer. Immunotherapy is also being looked at here, and we are also looking at immunotherapy in mesothelioma, another type of thoracic cancer. So the rest of the time we're going to talk about non-small cell lung cancer. I'm going to split it up into early stage without lymph node involvement and later stage with either extensive lymph node involvement or further involvement. Dr. Lee discussed the early stage in detail, but I do want to add on that there is a role for chemotherapy, particularly after surgery for stage 2 and stage 3 lung cancer, in our ability to prevent the cancer from recurring after surgery. But we mostly get involved for stage 4 lung cancer. That's where cancer is spread around the lung to the other lung or elsewhere in the body, most commonly the brain, bone, liver, and adrenal glands. Modern chemotherapy has become a lot better than in many people's minds. We have newer and very effective anti-nausea medicines that make it easier for us to deliver chemotherapy. A new drug called pemetrexed is particularly effective for the non-squamous or specifically the adenocarcinoma patients. We do use biologic drugs, bevacizumab, which improves our ability to deliver the chemotherapy to the cancer and does block some of the abnormal blood vessels that are feeding the cancer. And we have also learned that in certain cases, a maintenance therapy after our more aggressive induction chemotherapy, where we really try to shrink the cancer, we then maintain treatment at a lower intensity level over longer time. And sometimes we're able to get several years of ongoing cancer control without many chemotherapy side effects. So that is one thing that has really changed our standard of care and the quality of lives of our patients. Chemotherapy is still the mainstay of treatment for most of our patients, and we are also looking into new treatments that we'll go into in just a little bit, reviewing our general therapies for non-squamous, mostly adenocarcinoma. We do typically start with that pemetrexed drug I discussed, or a 3-drug combination, carboplatin, paclitaxel, and bevacizumab. We then use other drugs after that for second line or later. In squamous cell, we have found that a gemcitabine based treatment or a taxane treatment is often most effective. And then we use the other one for later lines of therapy. We'll now discuss targeted therapies, and this has really been a revolution across our treatment of many kinds of cancer. The concept is that mutations develop. These aren't mutations that a person was born with, but mutations develop either just due to normal aging or due to a carcinogen such as UV light from the sun or tobacco that can cause a specific mutation that is really the driving cause of the cancer. If you can identify that and block it with a drug, often you get very dramatic shrinkage of cancer, many times with minimal side effects. These drugs are usually oral drugs, and so it's really been a major advance. The most developed of these treatments is the EGFR inhibitors, which are Tarceva and Gilatrif, or erlotinib and afatinib. These are both oral drugs. ALK inhibitors have also shown major and significant advance, and we have new generation EGFR and ALK inhibitors that are being studied at UCLA now with many times as good or better efficacy than the initial drugs that were approved. There are other what we call targetable or treatable mutations, including ROS1, and we're looking at a variety of others. KRAS has been the most commonly found driving mutation, so really a high priority of ours to learn how to best treat. RET, FGFR, the list grows almost every year. The concept is that there are these proteins on cancer cells that act a little bit like a satellite dish and bring a growth signal that then attaches to that protein, or the protein is on a left in an on state, meaning it is always signaling the cell to grow. These drugs bind to that protein and stop its signaling, and thereby shrink the cancer and cause cancer cell death. This is one of the most important trials of this type of therapy. You'll see on the left there are two bars. The higher the bar is, the more patients had major cancer shrinkage. On the left, both of those lines, both of those bars represent patients who had EGFR mutations. And the green bar shows that more than 70% of patients that got an EGFR inhibitor had major cancer shrinkage. They also benefited from chemotherapy, but they benefited more from the EGFR inhibitor, often with less side effects. So that's become our standard of care, to start treatment with an EGFR inhibitor if patients have an EGFR mutation. On the right, those two bars are patients without EGFR mutations. And there you see the EGFR inhibitor has really minimal benefit, whereas chemotherapy still causes benefit for a significant portion of patients. A similar story comes from these ALK abnormalities, or we call them ALK translocations, where a genetic mutation-like event occurs that causes a growth signal to always be on in the cancer cells. By using another oral drug called crizotinib, or Xalkori, you can see that most patients have major shrinkage. There's a CT scan on the bottom. On the left is before treatment, and on the right is after treatment. All of that haziness in the lung that you see has completely disappeared. On the top, you have what we call a waterfall plot. The more of the bars that go down, that is showing us each individual patient that had a major benefit. And you can see that nearly all the patients have lines that go down and are benefiting from this drug. So these two types of therapies have really dramatically improved our care for these patients. We have looked to see in how many patients can we find driving mutations, and in the majority of patients with adenocarcinoma, we're able to find mutations. Similar studies have shown the same thing for squamous cell cancer patients. This may project a little bit small, but you can see The next problem that we have for these patients, this is a patient that was treated with Tarceva, an EGFR inhibitor. On the far left is before treatment. In the middle is after 4 months of treatment with a major benefit. Those numerous small nodules have essentially disappeared. But 2 years later, those nodules have started to come back. So the Tarceva was a significant, important treatment for this patient, getting 2 years of good cancer control. But what has happened? Why did the cancer become resistant to the Tarceva? This also may be hard to see, but in the majority of times that Tarceva stops working, it's because there's been a new mutation that we call T790M. This means that part of the protein has changed and developed a long arm. It's really a physical blocker that blocks the area that the Tarceva drug should attach to the protein. So really it's like a gate has closed and the drug is unable to get to the place where it needs to work. What we have developed is smaller drugs that get around that gate and still get into that binding area. And what we have found is that we are again seeing major response rates in at least 60% of patients. And that has been another exciting advance that just came recently, and UCLA played a really important part of those trials. Lastly, I wanted to talk about immunotherapy, which has really transformed the way we think about lung cancer. Just 2 or 3 years ago, no one would have thought that immunotherapy would play such a big role in our treatment of lung cancer. And a new class of drugs called PD1 or PD-L1 inhibitors have shown that by encouraging the immune system to be more active and to identify these cancer cells as abnormal, we are able to get a patient's own immune system to fight the cancer, and in a portion of patients get a major benefit. What is really exciting is that those patients that get a benefit, that benefit seems to last a long time. On average, at least a year, but possibly, as we learn more information, significantly longer than that. We are also developing new strategies so that even more of the patients we treat with this immunotherapy may have a benefit. Most of these drugs are what we call checkpoint inhibitors. Essentially, the immune system has checkpoints that prevent your immune system from being overactive. Cancer cells often sabotage that system, take over that system, and essentially turn that blocking or cloaking system on so that the immune system doesn't see it. These checkpoint inhibiting drugs prevent the cancer cells from being able to do that and allow the immune system to fight the tumor. So here's an interesting part of that type of treatment. On the far left, you see 2 CT scans, slices of a patient's lungs with 2 tumors. After a couple months, the tumors seem to grow, but what we found is that some of that time, it's actually the immune system fighting the cancer, causing inflammation that makes it look like the tumor's growing, but a few months after that, those tumors may nearly disappear, as we see here. So what I want to leave you with is that cancer therapy has changed dramatically in the last few years. UCLA has played a very important role in that, and we're very excited to be a part of it. We're now going to bring Dr. Ali back on, and I believe we are available for questions.
So there's several questions that were asked here, and I'm going to cover a couple of these. One of them is, how effective is lung surgery for lung cancer? And I think related to that is, what is the prognosis for people with lung cancer? Well, this is very much stage dependent. In early stage cancers and in kind of the intermediate stage cancers, complete resection, and did the surgeon get it all out with what we call margin negativity. We check the cut edges and make sure that the cancer is entirely out. So was it a complete resection? Did we get it all? Secondly, the lymph node status, whether the lymph nodes live in the lung itself or lymph nodes outside of the lung in the center compartment called the mediastinum. Both of these are important for prognostic value and also treatment approach. This defines whether patients should get chemotherapy or chemoradiation beforehand, before surgery, or whether they get it after surgery, or if at all. Not everybody is going to need that. So the prognosis is very much stage dependent. In the earliest stage lung cancers, stage 1 cancers, patients can have 5-year survivals upwards of, on average, about 80%. That doesn't mean patients only live to 5 years. Studies show even longer long-term survival. It's just what's quoted often are these 5-year survivals. A second question that is asked here is, what should I think about if I have lung surgery for lung cancer? Well, you know, when you see the doctor, the surgeon, the obvious thing that comes to mind is it appropriate for local therapy? Surgery is a local form of treatment. We address the lung cancer itself in the lung. Other forms of local therapy are radiation or cryoablation or radiofrequency ablation. These are all local treatments. So is the stage appropriate for a local treatment, or is the stage more appropriate for systemic therapy where we treat the entire body? So the accurate staging is important, and appropriateness for local therapy. I also tend to think about it as assessing the risk profile of a patient. Common heart-lung studies to assess what is the status of the lungs. Can a patient withstand lung surgery, and how much lung can actually come out? Cardiac studies that predict complications. So these things are important. When you think about a surgeon that you're potentially picking for or choosing to have performed the surgery, I would recommend a board-certified thoracic surgeon. These things are defined in the Society of Thoracic Surgeons website about what thoracic surgeons are. It should be an individual with expertise in both minimally invasive surgeries as well as open techniques. And that individual should have experience where a bulk of their practice involves lung surgery, not just the occasional lung surgery that he or she may be performing. And ideally, it should be done in a high-volume center. I think these are the most important things when you think about before having lung surgery and prognostic value. Any other questions on here? Mm-hmm. The other things that contribute to long-term survival after surgery is whether patients needed additional therapies, and this includes radiation or systemic therapy. And I think how patients respond to that and tolerate that are important, and the stage is what determines whether a patient is at risk for recurrence. And recurrences can occur locally in the chest itself. This could be a new lung cancer that occurs in a different area of the lung itself. This could be what we call distant recurrence or a systemic recurrence, where it occurs in an entirely different organ site, like the brain, the liver, bone. These things are all very much stage dependent. It's not uncommon that patients need to have multimodality treatment that encompasses surgery, radiation, and some form of systemic therapy. Most who present in an early stage will not need those other treatments besides the local treatment. So it's very much stage dependent.
So I have a couple questions about alternative treatment for lung cancer. So we do discuss this quite a bit in my clinic. A lot of patients come getting advice from family, friends, and on the web or other practitioners. And I always urge patients to be very careful about the choices they make, that we want to look carefully about what's known about the safety of things that they're doing. We try to make a decision together about what an appropriate option is. Will chemotherapy take care of the cancer? So that's a very important question, and just like Dr. Lee was discussing, depends on the stage of the cancer. For a stage 2 or stage 3 cancer that has been removed by surgery. We do think that chemotherapy has a chance of preventing a cancer from coming back and essentially allowing or contributing with the surgery to have a cure. In other situations, when the cancer has spread beyond the lungs or is no longer removable by surgery, then unfortunately we are usually not able to take care of the cancer forever. But we do think, in fact we know, that treatment plays a really important role in having patients feel better and generally live longer. We are always discussing those choices with our patients, and we want to keep both quality of life and length of life in mind and keep in consideration what a patient's individual preferences and goals are. What I think is so exciting about our new therapies is that often we are not having to make any choices about the quality of life effects of our treatment. Our treatments are often so well tolerated that patients are just feeling better. Their cancers are under better control, and it is a real pleasure to see them getting back to the things in their life that they like and want to do. Thanks very much.